Carrying on now with problems related to coordination and movement. The objectives for this portion are to identify and discuss the etiology and pathophysiology of head injuries, think about the area that's affected and what you might expect, and look at strokes, the etiology and pathophysiology of stroke, ischemic versus hemorrhagic, and how we can deal with what area is affected. We're also going to look at collaborative care, nursing management, knowing our priorities, making up a plan of care for patients with head injuries, strokes, and monitoring for intracranial pressure. So we know that the head injury is any trauma to the scalp, the skull, or the brain. A serious form we call traumatic brain injury. You're going to see it as TBI. Statistics regarding the occurrence of these injuries are incomplete because so many do die at the scene. So that's a big portion of what's going on. Death at the scene will occur, but it will also occur later on. Here's some different ways that traumatic brain injury occurs. We see there mostly falls, but we also see auto accidents, struck, assault, and sometimes we just don't know what happens. Head injury has a really high potential for a very poor outcome. Deaths from head trauma occur usually at the scene. It can occur within 2 hours and then again within 3 weeks. So you think you're out of the woods and 3 weeks later, death. So it is constant vigil on this person. Majority of deaths occur after the injury, so right at the scene. The person dies right there from massive hemorrhage and or shock. Deaths occurring within a few hours of the trauma are caused by progressive worsening of the head injury. So again, constant vigil, constant watching this patient and monitoring. The location of the fracture determines the clinical manifestation. So where is it? What's going on? What portion of the head? What portion of the brain is affected? So you really have to do a very, very complete neurologic assessment. Watch out for NG tubes. I know NCLEX does like to ask this. It should be an oral gastric tube. I know in some cases they do an NG tube. Whatever is inserted should be under fluoroscopy with a doctor. It shouldn't really be the nurse doing this for a head injury person. Every person with a head injury should be monitored very, very closely for 24 to 48 hours. The big thing I want to get across here is that when it says it's an open fracture of the skull, the biggest, highest risk is for infection. You always have to think about infection. What's their temperature? What are their signs and symptoms? Fever, chills, anything like that. Raccoon's eyes and battle sign. I don't know about NCLEX, but CCRN and the CEN love to ask about raccoon eyes and battle sign. So raccoon eyes, just what it sounds like, black and blue or ecchymosis around the eyes, so the orbits that are affected. And then battle sign is the black and blue behind the ear or periauricular. And you may have some drainage from the ear. You may have some drainage from the nose. Drainage from the ear, otorrhea, and of course from the nose, rhinorrhea. Discourage at all costs the patient from blowing their nose. That will increase intracranial pressure. You may have to put some kind of a little drainage sort of pad underneath so that you can see what kind of drainage and test that. We'll talk about that soon. When you see these things, this is associated with a tear in the dura, and then you've got leakage of cerebral spinal fluid. Brain injuries are categorized as diffuse, so meaning generalized, or focal, meaning localized into one area. They are also graded by the Glasgow Coma Scale. That is very easy to find in your book. I think we have one on here, but if not, we will get one in the modules for you. So all of us should be sitting at a 15 right now. I certainly hope so. After that, so that would be a minor head injury or no head injury at all, as I hope is the case for all of us. So 15 would be normal. Now, going down, 9 to 12 is really bad. That's moderate. And then severe would be 3 to 8. And you hear the phrase under 8, intubate. Now, what we're looking at for the Glasgow Coma Scale is eye-opening, verbal, and motor response. So eye-opening, somebody comes up to the patient who has their eyes closed and says something and the eyes spontaneously open. And that should be, and I know I've done it to people in class. So you would get the full points for an eye-opening. For verbal, is the speech clear? Is it garbled, or is there none? And then for motor response, same thing. Is it automatic? When we tell you lift your hand, you're lifting your hand and things like that. Is there none, or is it shaky, or it is graded like that? Now, even a dead person gets 1 point for each of these. So 3 is as low as you can go. So even dead, you get 3 points. Diffuse injury, concussion. This is a lot of times people just lose consciousness for such a short time. I think of it with my hockey players. They go down, maybe they lost consciousness, nobody even noticed, and the trainer will come over and ask some questions. So concussion is a sudden transient mechanical head injury with a disruption of neural activity and a change in the consciousness. So brief or not. Typical signs of concussion, so nausea, headache, maybe a short period where they don't remember anything. If the patient doesn't lose consciousness, or if it's less than 5 minutes, maybe you can monitor the patient. But for the most part, you really want them evaluated. The seriousness of a concussion is based on the length of time when there was actual loss of consciousness. So we want to document how long. Does anybody know? Maybe if they were found down, we have no idea. So we just want to know how long it lasts. For post-concussion syndrome, a lot of athletes, as you know, have gone through this. So post-concussion syndrome, persistent headache, lethargy or fatigue, changes in their personality. So you say, well, with somebody with dementia, how can you tell? They are changed from what they were before. They might have been pleasantly demented, now they're aggressive, or vice versa. Shortened attention span, and they can't concentrate. Most athletes will say they have a difficulty concentrating. For the RNs, when we did this portion, I led them to a YouTube where there was a hockey player named Pat LaFontaine who was able to discuss some of the problems and go through a physical exam. So shortened attention span is one that plagues them. And also changes in intellectual ability. So the neurologist would have some different types of tests. You want to look over short-term versus long-term memory. So what happened yesterday? A lot of times the coaches or the trainers will come out and say, what did coach just say in the locker room? So you want to ask something other than what's today's date and so on. Diffuse axonal injury, this is widespread. You have a decreased level of consciousness, increased intracranial pressure, which is huge. We'll talk about that. We're going to talk about decortication and decerebration soon, and how we can use those to include in our assessment, and then global cerebral edema. So automobile accidents, sports, violence, falls, child abuse. Remember from last semester, shaken baby syndrome. These things would cause diffuse axonal injury. When acceleration or deceleration causes the brain to move within the skull, so back and forth, maybe you're hit from behind in a car, your brain goes back and forth suddenly. Sometimes brain cells will die as a result of this type of injury, and what happens then is swelling in the brain. This will increase pressure, and also shearing will cause some problems too. Focal injuries, these can be minor. Lacerations include actual tearing of the brain tissue. So this might be a penetrating injury. Sometimes, and not always violence. It could be an accident that happened at work, in the car, or just walking down the street. Tissue damage is really bad. We need a surgical repair, so we need to get these people to surgery as soon as possible. Because there is an opening, remember there is a big risk for infection. So we're going to see antibiotics being used, and they may even look into ruling out meningitis. If bleeding is deep in the brain tissue, then you're going to see more signs. We're going to look too at subarachnoid, intercerebral, and intraventricular hemorrhage. Contusion is a bruising of the brain, and this is usually caused with a closed head injury. So we can see hemorrhage, infarction, necrosis. This is somebody who's going to need to go to CAT scan. This is somebody who might even go to MRI. Seizure precautions should be in place. These are parts of your nursing planning. So if I'm planning to send a patient over to CAT scan or MRI, I want to go through for CAT scan, any metals, same with MRI, any metals on them, any implants in the eyes, pacemakers. Really assess that person for anything that can be a problem in either MRI or CAT scan. We want to look and make sure that their name band is on their body and is correct. We want to make sure that they've had any tests that are needed beforehand, like blood draws before they go over, anything like that. If there is an antibiotic to be hung, hang the antibiotic. Coup counter coup. This is the type where you went forward and then back, and it's called coup counter coup. It can have bad injury or minor injury. Again, you're going to be doing neuroassessments. Bleeding can occur both in the front and in the back.